All right, let's get started. Good morning. I'm David Steensma from the Dana-Farber Cancer Institute and Harvard Medical School in Boston. And it's an honor to be moderating this second press briefing of the 60th ASH Annual Meeting and Exposition here in San Diego. The title of this session is Big Trials, Big Results, Novel Agents for the Treatment of Blood Diseases and Disorders. And all of the trials we're going to hear about are substantial in size for the hematology community, at least. The cardiology community, they might be quite small, but for us, these are real meaningful trials. Before we begin, just want to remind everybody to just silence your cell phones, and if you can turn off the shutter sound on your camera, please do that. So we think that the studies that are going to be presented today will have implications for hematology practice, both in the United States and globally, and that they address some important questions relevant to improving the effectiveness and reducing adverse events of therapeutic approaches. So we're going to hear about 4 studies, and the first one, Dr. Peschel of the Saarland University Medical School in Homburg, Saar, Germany, is going to present the results of the Flier Trial. This is a long-term evaluation of patients with lower risk diffuse large cell B-cell lymphoma. And the study was focused on reducing the number of cycles of chemotherapy that the patients could receive. And was an international analysis, almost 600 patients, median 5-year follow-up, and their key finding was that patients could, in many cases, reduce the number of cycles from the current 6 down to 4, and thereby reduce adverse events and get done with treatment sooner. Second, Dr. Jennifer Wyach of the Ohio State University Comprehensive Cancer Center is going to present results of a large-scale analysis of the benefit of ibrutinib in treating older patients with chronic lymphoid leukemia. Ibrutinib's approval for CLL is a little bit funny. It was compared to chlorambucil, which very few people use anymore. The standard of care for CLL in older patients has been the combination of bendamustine and rituximab. And the question that she's going to tell us about is, did ibrutinib or ibrutinib in combination with rituximab improve disease progression with respect to the comparison with bendamustine? And then finally, we're going to hear about a separate pair of studies that indicate that the experimental drug luspatercept, a ligand trap, can help patients with anemia that is due to different diseases. And first, Dr. Cappellini from the University of Milan in Italy is going to present the results of the Believe trial, which was a phase 3 randomized double-blind placebo-controlled trial in adult patients with beta thalassemia who were receiving red blood cell transfusions. And indeed, the study drug did reduce by at least 1/3 the number of red cell transfusions patients were getting over a 12-week period. And then finally, Dr. Alan List, the CEO of the Moffitt Cancer Center down in Tampa, Florida, is going to present the results of the Medalist trial, which we'll hear about at the plenary session tomorrow. This, too, was a phase 3 randomized placebo-controlled trial, double-blind, in patients this time with myelodysplastic syndromes who had ring sideroblasts and had either not responded to or were not eligible for treatment with erythropoiesis-stimulating agents for their anemia. And so Dr. List is going to explain further about that. And then once all these 4 presentations are done, we're going to open the floor for questions, first to those who are here in the room, and then eventually to the phone lines, as there are journalists who are calling in that way. And in order to make sure that we have enough time, and we'll make sure there is enough time, we ask that you just hold your questions until all 4 of the panelists have finished presenting. They're not going to give their whole presentations, of course, they're just going to give a brief version. And so without further ado, Dr. Peschel, I invite you to come up and give the first presentation.
Thank you. Good morning, ladies and gentlemen. Maybe you can help me with the first slide. Okay. Good morning, ladies and gentlemen. I'm pleased to present you the final results of our Flier trial on behalf of the German Lymphoma Alliance. In the Flier trial, we investigated the randomized comparison of 4 cycles of R-CHOP plus 2 cycles of rituximab versus 6 cycles of R-CHOP in young patients with favorable prognosis of diffuse large B-cell lymphoma. With regard to the background, we know from the MINT trial that there is a patient population with an excellent prognosis. Those patients present with age-adjusted IPI of 0 and in the absence of bulky disease. Those patients had a 3-year progression-free survival of 95% in the MINT trial. Therefore, it was our aim to investigate in the Flier trial whether we could maintain efficacy and reduce toxicity by reduction of CHOP cycles. Here you can see the design of our study. Patients were eligible for frontline treatment of aggressive lymphoma, B-cell lymphoma, if they were up to 60 years of age, had limited stage disease, an age-adjusted IPI of 0, and no bulk, defined as a maximum tumor diameter of less than 7.5 centimeters. Patients were randomized to receive either 6 cycles of R-CHOP21 or 4 cycles of R-CHOP21 plus 2 cycles rituximab. And this is the result for our primary endpoint, progression-free survival. The median follow-up time was 66 months. At 3 years, progression-free survival after 6 cycles of R-CHOP was 94%, with a 95% confidence interval ranging from 91 to 97%. After 4 cycles of R-CHOP, progression-free survival at 3 years was 96%, with a 95% confidence interval ranging from 94 to 99%. As the lower limit of the 95% confidence interval of our experimental arm was 94%, it is shown that it is definitely non-inferior to the standard arm 6 cycles of R-CHOP. These are the results for overall survival. There's also no difference between the 2 arms. At 3 years, overall survival after 6 cycles of R-CHOP was 98%, and it was 99% after 4 cycles of R-CHOP. Let's have a look at toxicity. First of all, the total number of hematological adverse events. 6 cycles R-CHOP led to a higher toxicity with respect to leukocytopenia and anemia, both of any grades and also of grades 3 to 4, in contrast to 4 cycles of R-CHOP. The reduction was about 1/3. And now coming to the total number of non-hematological adverse events, you see that after 6 cycles of R-CHOP, a total of 1,295 adverse events were reported of any grade, and in contrast, after 4 cycles of R-CHOP, 835 adverse events have been reported. This means that an overall reduction of non-hematological adverse events could be reached for about 1/3. And this was the case in the most common adverse events as paresthesia, nausea, infection, vomiting, and mucositis, both in toxicities of any grade, but also in toxicities of grade 3 to 4. To conclude, in younger patients with favorable prognosis of aggressive B-cell lymphoma, efficacy with 4 cycles of R-CHOP plus 2 cycles of rituximab is non-inferior to the previous standard of 6 cycles R-CHOP. Adverse events with 4 cycles were reduced by about 1/3, which means a significant benefit for patients, and the relapse pattern is similar in both arms with longer follow-up.
Dr. Wyatch.
Good morning, everybody. Today I'll be discussing the results of the Alliance-led NCTN study A041202, a randomized phase 3 trial of bendamustine plus rituximab versus ibrutinib plus rituximab in untreated older patients with chronic lymphocytic leukemia. We undertook this study to determine the most effective therapy for older patients with CLL, which makes up the majority of CLL patients. They have been traditionally underrepresented in clinical trials unless they are designed specifically for this age group. At the time that the study was designed, bendamustine plus rituximab was widely used in the community based upon excellent data in the phase 2 setting. During this time, the BTK inhibitor ibrutinib was just entering the clinic. Despite now widespread use in the front line, following FDA approval for this indication in 2016, the efficacy of ibrutinib versus standard chemoimmunotherapy has not previously been investigated. We also designed this trial to answer the question of whether ibrutinib given in combination with the CD20 monoclonal antibody rituximab would be superior to ibrutinib given as a single agent. The addition of rituximab improves both progression-free and overall survival when added to chemotherapy in CLL, but it has been unknown whether this would improve outcomes with ibrutinib, and this is the only phase 3 trial designed to answer this question. In this study, we enrolled previously untreated patients with CLL who were age 65 or older and met criteria for the initiation of therapy by IWCLL guidelines. Patients were randomized 1:1:1 to bendamustine plus rituximab, ibrutinib given at standard daily dosing until disease progression, or ibrutinib given in combination with rituximab. The study did have a crossover design, so patients enrolled on bendamustine plus rituximab who progressed had the option of crossing over to single-agent ibrutinib. 644 patients were screened for this study, and of those 547 patients from 219 sites across the United States and Canada were randomized to one of the 3 arms. The median age across all patients was 71 years, ranging from 65 to 89. 67% were male, and 97% had a performance status of 0 or 1. 6% of patients had deletion of 17p on central fish, and 19% had a deletion of 11q. TP53 mutation on central analysis was seen in 10%. ZAP70 unmethylated disease, which was defined as less than 20% methylation and equates to IGVH unmutated disease, was seen in 53% of patients. Besides this slightly higher percentage of patients on the ibrutinib plus rituximab arm having a complex karyotype, the 3 arms were well matched in terms of these baseline characteristics. In the eligible patient population, the progression-free survival was significantly higher in the ibrutinib-containing arms than the bendamustine plus rituximab arm, with a hazard ratio of 0.39 for ibrutinib versus bendamustine rituximab and 0.38 for ibrutinib plus rituximab versus bendamustine plus rituximab. There is no difference in progression-free survival between ibrutinib and ibrutinib plus rituximab. 24-month progression-free survival was 74% with bendamustine plus rituximab, 87% with ibrutinib, and 88% with ibrutinib plus rituximab. Median progression-free survival is 43 months with bendamustine plus rituximab and has not yet been reached for either of the ibrutinib-containing arms. The forest plot here demonstrates progression-free survival relative to our stratification factors. It's shown for only ibrutinib versus bendamustine plus rituximab because ibrutinib and ibrutinib plus rituximab were similar. You can see that ibrutinib is superior to bendamustine plus rituximab throughout, except for in those subgroup of patients with methylated ZAP70, which equates to mutated IGVH, where the trend is towards improved progression-free survival with ibrutinib, but does not yet reach statistical significance. At this time, we do not have a difference in overall survival among the arms, which may be due to the short follow-up as well as the crossover design. Because the safety profile of these agents has been studied extensively, our focus was primarily on grade 3 or higher adverse events that were of special interest with ibrutinib or were different among the arms. The adverse events presented here are all regardless of attribution, and because of the time difference of the therapies, they include all adverse events, both during active treatment as well as follow-up, excluding any crossover patients in the bendamustine rituximab arm. Hematologic adverse events, specifically neutropenia and thrombocytopenia, were more prevalent with bendamustine plus rituximab, whereas overall non-hematologic adverse events were more prevalent on the ibrutinib-containing arms. High-grade bleeding was uncommon and was not different among the arms. Atrial fibrillation was slightly more prevalent on the ibrutinib-containing arms, and hypertension was more common on the ibrutinib arms. Infections and sudden death, while numerically higher in the ibrutinib arms, do not reach statistical significance. In conclusion, ibrutinib and ibrutinib plus rituximab results in superior progression-free survival compared with bendamustine plus rituximab in the frontline setting for older patients with CLL. The addition of rituximab does not improve progression-free survival over ibrutinib alone. We do not have an overall survival difference at this time, likely again due to the crossover and relatively short follow-up. Importantly, though, BTK inhibition is not without toxicity in this age group, including significant toxicity, so close monitoring remains important, as well as strategies to limit toxicity through either the use of more selective BTK inhibitors or potentially limiting the duration of therapy are of great interest. And towards this goal, I just would like to mention the next phase 3 cooperative group studies, the successor to this trial, A041702, and the ECOG trial, EA9161, which will both open in December 2018, and address the question of whether ibrutinib in combination with venetoclax and obinutuzumab as a strategy for discontinuation is superior to standard ibrutinib therapy. Thank you.
All right. Dr. Wyach, thank you. Our third presentation by Dr. Cappellini.
Yes, good morning to everybody. I'm going to present the results of a BELIEVE trial on luspatercept in adults beta thalassemia patients who require regular blood transfusion. Beta thalassemia is an hereditary hemoglobinopathy due to a deficient or even absent globin chain synthesis, leading to ineffective erythropoiesis and anemia. Currently, the standard of care for these patients is a regular blood transfusion all long life and iron chelation to remove the iron accumulated by transfusion. So at present, still there is an unmet need in order to identify new approaches for treating these disorders, which is really very demanding. Luspatercept is a first-in-class erythroid maturation agent under development for the treatment of adult patients with beta thalassemia or MDS-associated anemia. Luspatercept binds to select TGF-beta superfamily ligands to reduce the aberrant SMAD2/3 signaling pathway and enhance the late-stage erythropoiesis. The BELIEVE study is a phase 3, double-blind, randomized, placebo-controlled, multi-center study comparing luspatercept plus best supportive care versus placebo plus best supportive care, as I already said, in adult beta thalassemia patients regularly transfused. 336 beta thalassemia patients were enrolled, aged more than 18 years, requiring transfusion, and transfusion dependency was defined as at least from 6 to 20 units of blood during the 24-week before entering the study. Patients were randomized 2-to-1. Dose on luspatercept started with a dosage of 1 milligram per kg plus best standard of care. The dose could be adjusted to 1.25, and the drug was administered subcutaneously every 3 weeks. After 48 weeks, the study is unblinded, and we are at this stage now. So the primary endpoint of the study was to observe a reduction of equal or more than 33% in transfusion burden from baseline, with a reduction of equal or more 2 units during a fixed period, precisely from week 13 to 24. The key secondary endpoints were, again, the observation of a reduction of equal or more than 33% unit of use of blood from baseline in another fixed period, week 37-48, and then a reduction of more than 50% again during the 2 fixed periods. Moreover, as secondary endpoints, we look at the mean change in transfusion burden from baseline at week 13-24. There was an additional endpoint, which probably is the most relevant and most adherent to the real life, and it's the achievement of more than 33% reduction in blood transfusion burden from baseline over any consecutive 12 or 24-week over treatment. So this is the rolling in methodology. 65 sites participated in 15 different countries, which is important because it is quite representative of the world thalassemia population. As for the primary endpoint, luspatercept definitely met the primary endpoint, showing a statistically significant reduction in transfusion burden compared to placebo, as you can see here, and the same for the secondary and additional endpoint. Also, all the key secondary endpoints were met. Luspatercept show a statistically significant reduction in transfusion burden compared to placebo. So in terms of safety, this population per se is exposed to several events, and we may say that any adverse event occurring during the treatment was mild, moderate, manageable, without requiring dose modifications or interruption. No deaths were observed during luspatercept. So at this point, we may conclude that luspatercept showed a statistically significant reduction in transfusion burden compared to its placebo, at least 33%, 1/3. Luspatercept achieved also a statistically significant reduction in transfusion burden in other 2 fixed periods, and some patients achieve a reduction more than 50%. Luspatercept achieved a reduction in transfusion burden across any 12 or 24-week analysis. That's the most important observation. It's well tolerated in this population, so at this stage we may say that luspatercept is a potential new therapy for adult patients with beta thalassemia who require regular blood transfusion. This is the other.
And then our final presentation by Dr. List regarding the Medalist trial with this same compound in MDS.
Thank you, Dr. Steensma. Good morning, everybody. As you heard, the Medalist trial is a randomized phase 3 study testing luspatercept compared to placebo, a double-blind fashion in patients with lower risk MDS with ring sideroblasts that are transfusion dependent. So as a word of background, for patients with lower risk MDS, anemia is the most common symptomatic cytopenia that we deal with. And for most of these patients over time, the disease becomes transfusion dependent. And with that comes the attendant complications of iron loading. So recombinant erythropoietins, or what we call the erythroid stimulating agents, or ESAs, are the first line therapy that we consider for patients with lower risk MDS, specifically those without deletion 5q. And for patients who fail those or are intolerant of those or are unlikely to respond, we have a limited number of choices of drugs to offer. So luspatercept, as you just heard, is a first-in-class erythroid maturation agent that's under development for the treatment of patients not only with beta thalassemia, but also MDS-associated anemia. Luspatercept is a soluble receptor chimera that binds to an array of TGF-beta superfamily ligands to reduce aberrant SMAD2/3 signaling, and as a consequence of that, enhance late-stage erythroid maturation. In a large phase 2 study that was done in Europe, testing luspatercept in patients with lower risk patients with MDS and symptomatic anemia, patients with MDS and ring sideroblasts had a higher response rate. And that was the rationale for studying that subset of patients in the Medalist trial. So as I mentioned, this is a double-blind phase 3 study. Patients that were eligible for this had to have a diagnosis of MDS with ring sideroblasts, defined as either 15% ring sideroblasts in the bone marrow or greater, or having 5% or more ring sideroblasts with an SF3B1 gene mutation. They also had to have lower risk MDS defined by the IPSS revised criteria, including both the very low, low, and intermediate risk categories. They also had to be red cell transfusion dependent, receiving at least 2 units every 8 weeks in the 16 weeks prior to randomization. And they also had to have less than 5% bone marrow blasts. And finally, they had to be refractory to or unresponsive to ESAs or not good candidates for ESAs based upon transfusion dependence and a higher serum erythropoietin level. Patients were randomized in a 2-to-1 fashion to receive luspatercept, beginning at a dose of 1 milligram per kilogram subcutaneously every 21 days, or to placebo. And the dose of luspatercept could be escalated during the treatment to as high as 1.75 milligrams per kilogram every 21 days. The MDS disease assessment was performed, as well as response after 24 weeks of treatment, and then every 6 months thereafter. And patients were followed for at least 3 years after their last dose of treatment for AML progression, as well as their subsequent treatment and overall survival. The primary endpoint for the trial was red blood cell transfusion independence for at least 8 weeks or longer within the first 24 weeks of therapy. Some of the key secondary endpoints included red cell transfusion independence greater than 12 weeks in the first 24 weeks and also within the first 48 weeks. Some of the additional secondary endpoints was erythroid hematologic improvement, defined according to the International Working Group criteria of 2006, which includes a reduction in transfusion burden by 4 units or more every 8 weeks in patients that are heavily transfusion dependent, or a mean hemoglobin rise of 1.5 grams per deciliter over 8 weeks. We had 65 centers that participated, enrolling patients between March 2016 and June 2017. As you can see, this included the United States, Canada, and centers throughout Europe. So as you can see, that there was a greater portion of patients that achieved red blood cell transfusion independence, the primary endpoint. 58 of 153 receiving luspatercept, or 37.9%, compared to 10 of 76 on placebo, that's 13.2%. And it was highly significant with a p-value of 0.0001. I might point out that patients on the placebo arm that responded had a very low transfusion burden at baseline, and they exceeded that 8-week threshold for response simply by virtue of changes in transfusion pattern compared to baseline. For the key secondary endpoints, overall 28% of patients on the luspatercept arm achieved red cell transfusion independence for 12 weeks or longer. On the placebo, that was 6 or 7.9%, and again, that was highly significant. And also, overall, about 52.9% achieved hematologic improvement, as I mentioned the definition earlier, with luspatercept treatment compared to 11.8% on placebo. I didn't mention that the median rise in hemoglobin in patients that achieved transfusion independence was 2.55, reaching as high as 4.1 grams per deciliter. This was a very clean drug and very safe drug. There were no differences in treatment emergent adverse events and absolutely no differences in severe adverse events or the frequency of progression to AML. So in conclusion, treatment with luspatercept resulted in a significantly higher portion of patients who achieved red blood cell transfusion independence compared to placebo, as well as erythroid hematologic improvement. It was very well tolerated, and those responses were durable, with approximately 40% of patients remaining transfusion-free after 1 year of therapy. So luspatercept is a potential new therapy that we think could be very effective in patients with lower risk MDS with ring sideroblasts who are red cell transfusion dependent. Thank you.
All right, thank you, Dr. List. So now that you've heard...
Just a statistical fluke.
Thank you for asking that. I don't think it is because of adverse events. We only had 2 therapy-related deaths in the standard arm and none in the experimental arm. And also, with the longer follow-up, there's no big difference between the arms. We have to look for longer toxicity, follow-up for longer late toxicity, of course, but this is a little bit too early to have a look at that.
Yes, sir, over. Oh, Adam.
Dr. List, Adam Feuerstein from STAT. Could you speak to the clinical meaningfulness of that sort of the 25% transfusion reduction benefit that you saw in the study? I mean, is that strong? I mean, maybe sort of characterize that a little bit.
A little bit more. So it was 37% had achieved transfusion independence, and what I didn't show is the overall duration of transfusion independence. That median doesn't sound that is around 31 weeks compared to something around 10 weeks on the control arm. But the important thing is it's maintained in 40% of the patients for a year or longer. The other piece of this is that these patients were relatively heavily transfused. And overall, those 2 hematologic secondary endpoints that we had, a 4-unit or greater reduction in transfusions was reached in well over 50% of patients on the luspatercept arm. That's a major reduction. And with that, we also saw a decrease in ferritin over time with treatment, which we did not see in the placebo arm. Ferritin levels just continued to increase. So it was impactful for decreasing iron loading and also potentially for quality of life.
Dr. Poschel, this is Alex from Medscape. In a NASH release, you've said with the reduced chemotherapy, patients get back to life, their daily life quicker, and to their families and stuff like that. Are these anecdotal, or do you have quality of life data on this? Question one. And the other question, shorter one, is can you generalize this observation to all patients?
Unfortunately, we did not ask for quality of life CRFs to be filled out by patients. So it is just, well, yeah. But as toxicity is less, it is quite obvious that patients benefit from that. And your second question, whether we could generalize, well, not in high risk, never, definitely not. In this patient population with really low risk of aggressive lymphoma, in this patient population we can generalize, but not for all, definitely not. Yes, if they have age-adjusted IPI of 0 and tumor diameter less than 7.5 centimeters.
Okay. Over back there.
Annette Brindle from BioWorld. I have a question for Dr. List and then one for both Dr. List and Dr. Cappellini. So first, can you explain very quickly what ring sideroblasts, like what they are and what they mean in terms of, is this more or less serious disease? Is it easier and more challenging to treat? And then the second question I have for both of you, given what you know about the drug and how it works and the diseases and how they're the same and different, a priori, was there a better chance of this working in one or the other? Does one surprise you more than the other? What are your thoughts about sort of the relative the trials relative to each other? Thank you.
Yeah, well, maybe I begin with the ring sideroblast, and it's a morphologic subtype of MDS, and it happens to be very closely associated with the SF3B1 mutation. In fact, approximately 90% or more of patients had that mutation on the study. And with that, there's ineffective processing of iron, so what that ring is, what you see is punctate depositions of ferritin type of iron in the mitochondria, which circles around the nucleus, which creates the so-called ring. It actually is a very favorable subtype of MDS. These patients is the only gene mutation that's favorable in MDS. They live a long time, and in fact, if you look at trials for non-deletion 5q MDS, this is the most common subtype that you'll see. Now, whether this is specific, the treatment is specific for this or not, it's not clear. There's no doubt that looking at serum levels of some of these ligands, such as GDF11 and some of the bone morphogenic protein levels, they are higher in patients that have MDS with ring sideroblasts. As far as the rationale in MDS, and I can speak to that very quickly, we've known for years that the TGF-beta family has been very important in suppressing erythropoiesis in patients with MDS. And in fact, there's many publications, preclinical studies that have been done that have shown that. This is obviously had a strong rationale biologically to take this forward in patients with MDS. And in fact, in the phase 1 study that was done in normal volunteers of postmenopausal women, they developed erythrocytosis and had to stop because of the effectiveness.
Well, as for thalassemia, I may say that thalassemia is the really good target because the driver of the pathophysiology of thalassemia is ineffective erythropoiesis, which means that due to the inability of producing hemoglobin, in the bone marrow, the erythroid precursors die early, in an early stage. Going back to the mechanism of luspatercept, targeting or inhibiting the pathway of SMAD signaling, that was perfectly fitting with thalassemia. So knowing or having the preliminary information about the mechanism of action, thalassemia was the first selected population to look at. And I think it makes sense.
Yes, thank you.
Charles Bankhead, MedPage Today. A question for Dr. Wyach. Are there other groups of patients who might still benefit from the combination of ibrutinib and rituximab? It seemed to be comparable in this, just so ibrutinib alone would seem to be suitable for this group, but are there still other patients who might benefit?
So that's a good question, and I think all of the data that has been presented suggests that there's probably not a group, especially in the older patient population, who will do better with rituximab. I can tell you just anecdotally, some patients who I probably might still consider the combination would be those who have autoimmune hemolytic anemia, that you're also trying to control the anemia at the same time, or potentially those that have just a really, really high white count at baseline, but that would really be the exception, not the rule. However, in the late breaking session on Tuesday, you're going to hear the results of the ECOG study, which their comparator arm was not ibrutinib alone, it was ibrutinib with rituximab.
Does CD20 expression matter in the addition of rituximab and CLL? Or?
Basically, all CLL expresses CD20. It is relatively lower expressed in CLL compared to lymphomas, of course, but I don't think there's been any data to suggest that higher levels of CD20 affect expression.
Okay. Bowser.
Thanks. So my name is Andrew Bowser, and I'm with Hematology News. This question is for Dr. List regarding the Medalist trial. This is a phase 3 trial looking at luspatercept versus placebo. And I believe, or correct me if I'm wrong, but I believe a study just started looking at luspatercept versus ESA in the phase 3. What do we know about luspatercept at this point in comparison to ESA? Would this be, do you anticipate this would be a reasonable alternative to it, potentially better than ESA? Obviously with the limitations of not having any phase 3 data to comment on that, but could you talk about what is the potential for this in patients who have not failed or an ESA?
Yeah, that's a good question. And in the European trial, the phase 2 study that was done in lower risk patients with MDS and symptomatic anemia, they included patients also that had not received ESAs. It's a very small number, and they responded equally well. And what's important, when you look at patients who are going to respond to ESAs, there's two factors that predict response. Number one, very low transfusion burden or absence of needing transfusions. The other one is a serum erythropoietin level that's inappropriately reduced or low, so less than 200. This luspatercept worked in this trial, and I didn't show the data, I'll show it tomorrow, regardless of serum erythropoietin level. And obviously these were all patients that were transfusion dependent. So my expectations is it will be very favorable compared to an ESA, and probably more effective because it will work in patients that are transfusion dependent, and also regardless of serum erythropoietin level.
Okay.
Hi. I'm sorry.
Oh, sorry. I couldn't see with the podium there. Go ahead.
It's following up, so that phase 3 that you're talking about is a first-line trial? The trial that Andy referred to is
yes, that's a first-line trial.
Okay, and also it was interesting to me that your placebo group had some response when you stopped it, so, and you said they were at baseline, they had a lower burden. So were the groups balanced?
No, that's not. They were very well balanced. So the difference is the people that were clarified as a responder on the placebo trial, on the placebo arm, had very low transfusion burden. So they may have only received 2 units within 8 weeks, and just a change in that pattern could exceed 8 weeks to call them a responder. So the transfusion pattern was enough to call that a response. What they didn't have is, and I didn't show, you'll see it tomorrow, no robust rise in hemoglobin like you see on the luspatercept trial. So it was simply a change in the pattern of transfusions compared to baseline.
Thank you. And Dr. Wedge, what was your follow-up time? It's different from the abstract? I mean,
it's 38 months.
38 months now. And where does venetoclax fit in this now that you have data showing ibrutinib is so good?
Well, venetoclax isn't approved in CLL in the frontline setting. So, right now, I would say ibrutinib is a standard of care for this patient population. Though, as you know, there are accumulating data to suggest that venetoclax might be a good option in these patients too, but we don't have any head-to-head comparisons.
Okay, Mr. Bankhead.
Charles Bankhead again. Question for Dr. List and then one for Dr. Steensma. Does this therapy have any role or any potential in patients who are at risk of transformation?
Patients that, you said again, patients with?
And risk of transformation.
Risk of transformation. The mechanisms of causing ineffective erythropoiesis in MDS really differ in lower risk compared to higher risk disease. So I think that it's unlikely that it's going to be used there, but clinical trials would tell us. It also is being studied in anemia and other diseases such as myelofibrosis as well.
And when we sort of wrap this up, could you sort of offer your take on the impact of these different studies,
sure.
Clinical implications?
Yeah, sure. I will add to one thing Dr. List mentioned a moment ago. I think that the Medalist trial, the responses in the placebo arm, highlight one of the challenges in formally measuring clinical responses in myelodysplastic syndromes, given that the course fluctuates a little bit, and there's just been a proposed revision to the International Working Group response criteria that hopefully will help clarify that a bit in the future, because it is a challenge in some of these patients to assess true responses. It's over there.
Hi, Madeline Armstrong from Vantage. I've got a couple of questions for Dr. Cappellini. So in Believe, obviously it met the primary endpoint, but I've seen some comments that maybe it was less impressive than what was seen in phase 2, but then you've highlighted this alternative endpoint. So do you think there might have been a problem with the study design if you had used this as a primary endpoint? And secondly, just wondering how luspatercept fits in to practice, with gene therapies sort of coming along. Thank you.
As for the first question, actually, you are right. It's much better to follow patients with the rolling in methodology, because patients are different one by one. So they may respond in a different time and not precisely in a fixed period. We in this phase 3, we add this additional endpoint, and for the future, definitely that will be the way to prove the efficacy, the reduction of transfusion burden, and to use it in a real life. Because again, I said, these are quite complicated and heterogeneous patients. They may start with a different level of ineffective erythropoiesis, so the response can be different. And the rolling in methodology is the best. We have to keep in mind that these are young adult patients transfusing 3 units of blood every 3 weeks for all their life. So it is really a substantial impact, this treatment. As for gene therapy, definitely gene therapy is now an alternative treatment for beta thalassemia. Many data will be presented at ASH this year. To my point of view, gene therapy must be, to be really efficacious, a cure. Yes or no? I mean, you are not going to perform gene therapy for reducing the transfusion burden. That's not the scope. So I think that still there is a way to go to achieve this point. The other issue is probably the cost, but that's not part of the scientific consideration. I think that we have to wait and see. There will be other new approaches, alternative to gene therapy. Luspatercept is definitely the most advanced. Other new approaches modulating the iron metabolism are in preclinical study. So there will be few years of challenges for the treatment of thalassemia. And I should say also sickle cell disease.
Other questions up in the front here?
Hi, I'm Mariana from Global Data News. A question for Dr. Viola Poschel. So in addition to age group and tumor size, is there potential to use molecular biomarkers to identify these patients, low-risk patients who could respond to only 4 cycles?
Well, we have not looked it up yet. So we'll do that. That's a very good idea, but we have not done that before. And but those patients, they do so well. It is difficult. What we will do is to look at those patients that relapse. We will look whether they have a different biology and or whether those are de novo lymphoma, to identify those who don't respond to that treatment.
All right. Well, I'm told that we don't have anybody on the phone lines that has any questions, so we will sum up, and I was asked to just give a sort of brief take-home message, so I'll editorialize briefly here. I think beginning with the Flier trial, we're certainly always looking for ways to make treatments easier for our patients, to reduce adverse effects, and certainly for this well-defined subgroup of patients, it appears that we can make them their treatment shorter and have less burden, but equivalent efficacy. We can't extend that, though, to other subtypes of large cell lymphoma, but that's always a laudable goal. So I think this will immediately influence clinical practice. With respect to the presentation regarding ibrutinib up front, this is already being done in the clinic, and some of the questions alluded to, what about these other agents? We've had other agents just approved, dualisib, there's venetoclax out there. Again, these have been primarily in the relapse refractory setting, but I think this really does indicate that ibrutinib as frontline therapy, which many clinicians have been doing, is a very reasonable practice. And then finally, luspatercept, clearly an active drug. The safety profile really seems quite benign, and I think in thalassemia, where this fits with respect to other therapies such as gene therapy, time will tell. And in MDS, this will be a useful thing, I think, for us to have for our patients with ring sideroblasts, which are about 25% of patients overall, but are clearly overrepresented among the clinic population who are in getting transfusions because they do have quite significant anemia. So, cost effectiveness and that sort of thing above my pay scale. We'll have to certainly watch out for that, but it will be helpful, I think, to have this new addition to our MDS treatment armamentarium. It's been 12 years since we've had an FDA-approved drug in MDS. There have been 7 in AML in the last year and a half, so it's our turn, I think. Thank you for your attention.